Check, check.
All right, we'll go ahead and get started. So it's my honor to introduce our speaker today, who is Kristina Rother. She is the section chief in Pediatrics, Diabetes Metabolism, Diabetes Endocrinology, and Obesity branch at the NIH. Kristina did her medical training initially at the Albert Ludwigs University in Freiburg, Germany, then Master in Health Sciences at the NIH in Duke, did her residency at the Mayo Clinic as well as endocrine training in Zurich, followed by a fellowship in pediatric endocrinology at Mass General and the Mayo Clinic, and then has been at the NIH since 1995, where, as I mentioned, she's currently the section section chief. She's published over 100 papers in the areas of type 1 and type 2 diabetes, islet cell transplant and beta cell function, artificial sweeteners, which she'll talk about today, GLP-1 analogs, lipodystrophy, overgrowth syndromes, and intracellular signaling. And today she's going to talk to us about an area interesting for us in terms of diabetes, but also general pediatric health and metabolism, about how non-nutritive sweeteners influence hormones and health. So please welcome Dr. Rother.
Good morning, everybody. So it's a truly great pleasure coming back to Minnesota, where I spent 5 years of my life. And today I'm going to present something to you that actually was not really the topic of my clinical practice nor research. Artificial sweeteners kind of came on the side, and a door opened into a new field. And I could imagine that every one of you here has an opinion about artificial sweeteners, whether you should or shouldn't use them. I would have almost loved to do a pre-exam with you, how you feel now, and then how you feel later. But before I go into the talk, I want to let you know that I have no financial disclosures, and I will not discuss off-label or investigational use of products. What I'd like you to take from the talk is more than this. I had to kind of home in on two things. Namely, one is the distribution of sweet taste receptors in the human body. That might surprise somebody here, and understand the mechanisms that may explain the link between artificial sweeteners and obesity. Before I start getting to the artificial sweeteners, I want to make a pitch for the NIH. And this is that I often hear that people say, so you have regular patients there? We see, regular Hashimoto's thyroiditis and all this stuff. Yes, we do. We have a 200 inpatient bed hospital. We have 15 outpatient clinics. We see a lot of the patients as outpatients, 1,600 clinical trials, and more than 4,500 inpatients versus 95,000 outpatients in 2018. So yes, we are a real hospital, People can self-refer or can be referred. Everybody can come to the NIH, and the good thing is you don't pay. We have a pediatric endocrine program, and I don't want to get into trouble here, but I want to say, come and interview in our place too. We have 2 fellows a year, a 3-year program with 2 years of focus on research, and the possibility, that's really something nice, that when you're done with your fellowship, you can possibly stay if you get along with your mentor and do another year or transition into this assistant clinical investigator position. We also have loan repayment, and if you want to, you can get this master's degree in clinical research, which is a combined program with NIH and Duke. So it may be worth thinking, I'm also talking to especially pediatric residents, because you are the guys who have to think about your future. Pediatric endocrinology, why would you choose that? If you haven't quite decided yet, this is the reason. Because there's something for every organ. Whether it's the brain, and we do neuroendocrine tumor research with Stratakis, growth, bones, type 2 diabetes, type 1 diabetes, of course, CAH, I don't know whether Kiki is already here, but this is her colleague at the NIH, Debbie Merck. We have obesity research with Dr. Janowski, lipodystrophy, adolescent gynecology, and then myself with the nutrition now. So if you don't know in which direction to go as a pediatric person, endocrinology is a great subject because you don't need to specialize very early on. And with that, switching to the artificial sweeteners, I want to do a quiz with you. So you may know about the EPIC study, which is the European Prospective Investigation into Cancer and Nutrition. And what EPIC does, they follow 25,000 people. In this study, they had a follow-up of almost 11 years. And they look at the connection between, for example, the intake of sugar-sweetened soda, of chocolate milk versus coffee and fruit juice. And they look what happens with regard to diabetes. What's the chance that you develop type 2 diabetes? And you can, in your head, kind of already predict that, yes, of course, sugar-sweetened beverages and the milk increase your risk of developing type 2 diabetes, versus coffee should actually be somewhat protective, and fruit juice doesn't make a difference. So you see that little bottle in the middle, the not bottle, but a can, diet soda. Where do you think the bar is going to be with regard to diet soda? Diet soda, no calories. Okay, here it is. Exactly the same as the sugar-sweetened soda. So let's do this again. Framingham. So this is, these are individuals, that's why the N is only 2,600. These are individuals in the Framingham study who had liver enzymes as well as ultrasounds done in order to find out whether they have fatty liver disease. And what you can see here is that with the increase of reported intake of sugar-sweetened beverages, fatty liver risk increased. Makes perfect sense. How does this look like when you look at diet soda? Well, based on the previous experience, you can predict that too. Looks very similar. So somebody may say, hey, Kristina, did they adjust for BMI, for obesity? Well, when they reported what I just showed you, they hadn't. And when they adjusted for the existing obesity, they found that the relationship went away. So the relationship is based on obesity. That's what it is. And that's why the authors of these 2 publications said, well, you know, diet soda has nothing to do with type 2 diabetes and fatty liver disease, because it can be corrected by obesity, explained through obesity. And then we wrote a little article and said, wait a minute, I think the public will misunderstand that, because diet soda is related to these problems via obesity. So take that into account. Okay, let's go to the 6 artificial sweeteners that are FDA approved. What does it mean, FDA approved? They're generally regarded as safe, GRAS, and they have an upper limit of daily intake. This is this acceptable daily intake that's based on milligrams per body weight. And we have, when I say 6, we have aspartame, as you can see here, acesulfame, potassium, sucralose, saccharin, and then we have these super sweet ones, advantame, neotame. And why do I have all of these lines there? Because the problem is typically they're used as an admix, so it's not only one sweetener, it's very often several sweeteners in one product. And when you want to know whether you're reaching your so-called acceptable daily intake, you're out of luck, because the products need to be labeled with the ingredient. So if you look and you can read and you see acesulfame potassium, that means it's in there, but it doesn't tell you how much. So you cannot calculate whether you're beyond the so-called ADI. These 4 are the most commonly used artificial sweeteners: aspartame, acesulfame, potassium, sucralose, and saccharin. And only the ones in blue can be measured in plasma, in urine, because aspartame falls apart, is metabolized immediately upon ingestion, and it's metabolized into phenylalanine, aspartic acid. That's why there's a warning because of the phenylalanine. And there's a little bit of methanol, and there's a lot of whoop-de-doo about whether that methanol does something to your brain or not. I'm not going into this because there are no good data. I want to make one point very briefly, and this is about Truvia and stevia. So stevia is this plant, so that's why it's not an artificial sweetener. Stevia is a plant from which you get all of these compounds. You see here, stevioside, ribaudioside A, B, C, and so on. Somebody speaks Spanish, dulcoside, nice name, dulce. And the point is that stevia is made up of these various compounds, and they vary from product to product. Truvia is actually an artificial sweetener because they put in ribaudioside A, chemically engineered, and then you put a little erythritol, which is a sugar alcohol in there, and that's what it is. But it's still under the label of natural sweetener. It really isn't. We have not done any research on stevia, so I can't say much about it. I will talk about the other sweeteners that we can measure. So how do sweeteners work? Well, they are attached to sweet taste receptors. And I don't know whether there's anybody of my age still here who has this picture in the head of the tongue with these various areas where you have sweet here and you have sour there and so on. Well, forget it. There's just a tongue. And the tongue contains these various receptors, taste receptors. Of them, the receptors for sweet, bitter, and umami are very similar. They're G protein coupled receptors. They're dimers, and the sweet taste receptor is actually a heterodimer. And so you have these in the taste buds, you have about 50 to 100 cells in each taste bud. And each cell has only one type of receptor. So it's either bitter taste receptor, sweet taste receptor, whatever it is. We have 30 bitter taste receptors, which makes sense because bitter is danger. We have only one sweet taste receptor. So the sweet taste receptor, I think that's so lovely. It has a shape. These heterodimers come together and they have this venous flytrap at the end of it. And it looks like that plant. And that's where the sweet sugar or the sweeteners attach to the receptor. Okay, then once you get the sweetness on your tongue, it's being signaled to your brain, actually first here to the insula, and then it goes to hypothalamus and other places in the brain. So Important point is sweet taste receptors on the tongue and in the mouth. Actually, we have it in the entire pharynx also. They signal sweetness to the brain. If you were a fly, you'd also have sweet taste receptors, for example, on your feet. Now, here is this picture again of the person, of the endocrine person here. I just made a pitch. And this is where you have sweet taste receptors all over the place. Very important, you have sweet taste receptors in the gut. Now, when something sweet comes into the gut, for example, you put an NG tube down and you put sugar into the gut, you don't perceive it as sweet. So the sweet taste receptor name is kind of a misnomer because all over the body you have these same heterodimer receptors, but they don't signal sweetness. They signal other things. And in the gut, for example, they signal release of GLP-1, one of the gut hormones. So what are sweeteners used for? Well, they are recommended, and this here is actually a little pamphlet from the American Heart Association. You can see that in the upper corner here, American Heart Association, and they say life is sweet. Basically, you should swap sugar. You should swap other things for sugar, and among them are sweeteners. And what I thought was interesting is when you look at that pamphlet from the American Heart Association, you also see where they get their money from, because here is the support from Splenda, right? So Splenda is proud to support the age-8 Simple Cooking with Heart initiative. I think this is a little discerning, but what we are concerned about is safety. So for the past 100 years, saccharin was the first sweetener to be developed. We've been concerned about safety. Can they cause cancer? And here, my institute, or institution, and this is one of the institutes, the National Cancer Institute, has an answer to it. And I'm really surprised by the clarity of the answer. So there's, on the website, you can look up common cancer myths and misconceptions. And it says, do artificial sweeteners cause cancer? No. Well, I think that's a little strong. And there are still large studies coming out. Now, most of them are associations or epidemiologic studies, but the concern is still there that potentially blood malignancies, or lymphomas, for example, might be, that people with high intake might be at higher risk. So I'm just surprised by the categorical no. What we are concerned, and that's something when people say, well, the FDA has approved them, they're safe. The FDA looks at teratogenicity, they look at cancer, they do not look. There are no studies that need to be submitted for metabolic health. So whether there is a link to increased weight, diabetes, fatty liver, what I've shown you before, but these are epidemiologic studies, so there's no causality proven yet. But whether they are associated with these conditions, such as metabolic syndrome, lately you may have seen out of the Women's Health Study increased stroke and other negative health outcomes like premature deliveries. These things don't go to the FDA. This is not something that is evaluated when they decide whether this is grass, generally regarded as safe. So I feel that with this article, this was seminal. This came out 5 years ago, September 2014. And for the first time, it was established in an animal study that there is a causal link between artificial sweeteners and obesity or glucose abnormalities. So what this excellent group did, and you may have heard Eran Elinaf he has done a lot of wonderful studies. They did something very simple, namely they fed mice with various sweeteners. In the end, they published most of the data on saccharin. Then they scraped, and then they saw that the mice got higher glucose levels. Then they scraped out the intestine from these mice and put the bacteria into germ-free mice. And the germ-free mice developed the same glucose abnormality as the mice that got directly exposed. So you could transfer the problem with the glucose metabolism into the other mouse via the microbiome. So the conclusion is artificial sweeteners change the microbiome and cause the glucose abnormalities. So first time, really seminal study. In the meantime, the American Heart Association had actually a change of heart. So they now say, this is very recent here, the AHA recommends switching from diet drinks to water. So we were very happy about that. Of course, this is an accumulation of knowledge now at the AHA too, and we were proud that we contributed with 2 of our publications to their change of heart. So what I want to briefly talk about now are some of our own findings, namely prevalence of artificial sweetener consumption and exposure, then talk about the effects of on glucoregulatory hormones and exposure early in life, which is very dear to us as pediatricians. So when we looked at NHANES data, we found that 25% of children consume artificial sweeteners daily. 40% of adults consume artificial sweeteners daily. That's self-reported, right? The NHANES collects the dietary reports, and that's where we got it from. I want to say right away that these data are probably not exactly reflective of the reality. But just based on these data, we found a 200% increase of consumption in children over 2 decades. You know this yourself, before 20 years ago, children hardly drank diet soda. Now it is common practice. And 54%, so an increase of 54% in adults, also in pregnant women. So why do I say these data should be seen with a grain of salt? Because we did a little pilot study, and we asked 20 really smart, compliant college students whether they were, who were absolutely swearing they are not using any artificial sweeteners, to come and give us a urine specimen. And then we told them, look, the artificial sweeteners are in places where you don't expect them. Do you think when you eat a muffin that you should read the ingredient list, muffin, or your ketchup, or something like that? So there are lip balm. So there are many places where artificial sweeteners are, and you don't think, you know, it's not diet soda only. So we instructed them. They got it, they came back 7 days later, and then they were randomized into a diet soda or a water group. So 8 of 20 had sucralose in the urine in the beginning when they said they hadn't used any artificial sweetener, but they didn't really know the exact places where you can find them. But after they had been instructed to really watch out, 8 of 20 of these bright young people, and not the same 8 necessarily as in the beginning, still had the sucralose in the urine. And then when we randomized them to water or diet soda, 3 in the water group still had sucralose in the urine. So you could say, how long does sucralose Splenda, how long does that stay in the system when you ingest it? Well, it stays in the system about 5 days, actually. And Splenda is indestructible, or sucralose is indestructible. The water companies that have to clean your drinking water have great problem with sucralose and acesulfame potassium and saccharin. You can't get them out of the water. So we have in our water system here, Lake Superior contains artificial sweeteners, of course at very low concentrations, but they don't go away. So the distinction between non-consumers and consumers, especially for people who want to do a study, right, is probably artificial, because everybody is a bit of a consumer. There are high consumers and low consumers. And the other one is due to underreporting. The prevalence of artificial sweetener intake is much higher than what we reported based on NHANES. So here I want to show you something about glucoregulatory hormones. Simple study where you take 30 people and they come back 4 times. Each time when they come about a week apart, they get an oral glucose tolerance test. And before they drink the Coca-Cola, they drink either a diet soda or they drink water. And then we see what happens to their hormonal excursions over 2 hours. So these lines you see here, they are active GLP-1, for example, and the blue line always reflects water. So what you can see is that the other lines, especially the red one, diet soda, pre-treatment led to more GLP-1. What do you say? That's good, isn't it? I mean, when you increase GLP-1, that's why we have these various medications, GLP-1 analogs for diabetes. Yeah, good. But when we checked, did they have less hunger? Did they have a different motility? Because we also gave them acetaminophen in order to see how they absorbed the acetaminophen, to see whether there was a change in the emptying of the stomach. We didn't find any difference. So we feel that this, what we published here, there's a statistical difference, is probably not clinically relevant. What is more concerning is this one here, and that one didn't achieve clinical significance. Namely, if you look on this side here, the insulin. So insulin is also a little bit higher. Insulin leads to fat storage, holding on to your nutrients, and makes you potentially a little more hungry. So why insulin? Well, beta cells, I showed you before in that picture, beta cells have sweet taste receptors. When you activate the sweet taste receptors, together with glucose coming into the beta cell, you have more insulin secretion than if you have no sweet taste receptors on the beta cell. So it seems like artificial sweeteners might work a little bit like a loudspeaker. The voice is just a little louder, the signal to the beta cell produce insulin a little stronger. And this has actually in the meantime been shown in much better studies because they gave sucralose or Splenda chronically for 6 weeks or 4 weeks. And what they found is, yes, these people, healthy people, have increased insulin secretion and which basically is a sign more insulin for the same glucose means insulin resistance. So I think this subject is done. So yes, sucralose leads to mild insulin resistance even in healthy people. So how about exposure early in life? So infants, this was an abstract in 1984. They found that saccharin was in breast milk. And there's actually, if you go and you look what's recommended for pregnant women, there is a warning, may not be well advised to ingest saccharin. Now, so we looked around at the NIH, many young women work. We had an easy time recruiting 20 volunteers who gave us some of their breast milk. And 65% of the women had artificial sweeteners. And I'm talking about these three because these ones we can measure: saccharin, sucralose, and acesulfame potassium. Okay. So then what we did is we asked lactating women to have a diet soda in the morning and then express breast milk over 6 hours and see what happens. I mean, this is the breast milk that goes into the baby. So mom drinks the diet soda, and you can see here over this time frame of 6 hours that the line goes straight up. Same thing for acesulfame potassium. Why are there two lines? Because one is for obese women and one is for normal weight women, because we wanted to see whether obesity plays a role, but ultimately if you correct it for blood volume, there's no difference. The message is mom drinks the diet soda goes into the baby. So then we did, together with our colleagues in Phoenix, they have a very interesting study where they tried to see, actually they tried because they couldn't recruit much, and the study is now not recruiting anymore. They're just looking at the data. They tried to see whether intensive lifestyle management during pregnancy in obese women leads to better outcome of the babies. So we asked them whether we could have some blood samples from these pregnant women, and then there's birth, and then they were followed for 1 year. And they were so kind to give us these samples. And what we found is that in the blood samples, 80% of the moms, now these are Native American women, only Native American women, and supposedly Native Americans use less artificial sweeteners because they don't like it. The taste is different. But in fact, we found the same numbers as everywhere else, 80% positive in blood, 77% positive breast milk samples, and then, not so surprising, but still I thought was impressive, the cord blood. So babies born, at that time we didn't have blood samples from the mom, only cord blood sample, 71% contain artificial sweeteners. Okay, so we said, okay, so, you know, saying the stuff is there doesn't mean it does something. So how about testing whether artificial sweeteners in this early stage of life, they do something to the babies? And there my colleague Stephanie Olivier van Stikkelen came with her mice and said we could do something together. And we did. So we designed an experiment where pregnant moms are exposed to artificial sweeteners, and you can see here in amounts, this is down here, either control, they get nothing, or they get artificial sweeteners, these two, sucralose and acesulfame potassium, at levels of the so-called ADI. So this is what humans can ingest, and we just calculated it based on mouse weight. And then we gave them twice as much. So this is ADI times 2. So this is what the moms got during the pregnancy, and then also while the babies were still drinking breast milk, and then when they were weaned, we unfortunately killed them. So Stephanie learned to milk mice, no joke, because we wanted to know how much is in the breast milk of the mice. It's not an easy task. Okay, so what happened? Well, we focused on the microbiome. And you don't need to be a microbiome specialist to see here in these various components of a healthy microbiome. So these are, each line, each bar is one pup. So you can see that these pups have these verrucomicrobia, firmicutes, bacteroidetes. So that's a normal distribution. And that's what you see at one-time exposure of the ADI or twice exposure. So something's missing in the picture here. And what is it that's missing? This is the Akkermansia. What is that? So Akkermansia muciniphilia, so mucin, it's right there, is a bacterium that lives in the mucus of the gut and appears to be beneficial to general health and metabolism because they're trying it, whether it can actually reduce, as a clinical study, giving this bacterium, whether it can improve metabolic syndrome. So these baby mice lacked that bacterium, or not completely, but had much less. And then you have heard probably the ratio of firmicutes to bacteroides is also an indicator of metabolic health, and the ratio was worse in these offspring. What was also interesting is that when we looked at the livers of these guys, so this is the livers of the pups, the more they had been exposed to artificial sweeteners, these two, the whiter their livers became. And we tried to figure out why are they so white. So white could be fatty liver, right? First thing. So we stained for fat. It wasn't fat. Infection? No. The histology looked actually normal. So we think it's either anemia or decreased clearance, toxicity. And what we did is we did these metabolomic studies, and we found that the detoxification pathways are very much reduced. So basically, these mice cannot detoxify. And we think that these are toxic livers. Now, the next studies need to be done. This is just the beginning, namely, does this reverse when you do not expose them anymore? We stopped the experiment right there, and Stephanie moved on to the Midwest, so now we need to set up new collaborations. All right, one more point I want to make, and this is another pathway to obesity, and that's done by our colleague Sabi Sen at George Washington University. What he does, he works on cardiovascular disease, and he has these mesenchymal stromal cells, I asked him, I said, could you just expose them and see what happens? Expose them to some sucralose and just observe. And he did, and he saw a difference. And that difference can be seen in this slide here. So this is no exposure of these mesenchymal stem cells for 18 days, and that is exposure with sucralose, 0.2 millimolar. And he sees lipid storage. And when he looked at gene expression, he found a few interesting genes which just make you think that what had been seen in mouse studies, namely a promotion of adipogenesis. So you have immature, premature cells, and if you expose them to sucralose, for example, they develop more rapidly into adipocytes. So if you put these two things together, we kind of hypothesize that maybe if that happened in a baby already, that'd be not a very good thing. So you have the mesenchymal stem cells, they have three fates. They can either become adipocytes, chondrocytes, or osteocytes. Now, if you add your sweeteners, if they preferentially go into adipocytes, then that would be a link to obesity. And the other one is if they preferentially do not become bone cells, that would be an explanation for epidemiologic findings that people with high artificial sweetener consumption have lower bone mass. So I told you about microbiome changes, potential promotion of adipogenesis. Now there's one more thing that's important during pregnancy, and this is what mom eats. And you know there have been beautiful studies where moms were actually fed garlic. And the amniocentesis actually revealed that the amniotic fluid smelled like garlic. And then when you give a baby from a mom who ate a lot of this stuff an onion, she'll like it. So, or he'll like it. So what we're saying is, so in rat studies it has been shown that when rat moms were exposed to artificial sweetener during pregnancy and lactation, the pups that grew up at 6 months of age preferred sweet more than the ones that were not exposed. So what we are saying is there something that we kind of imprinting these babies with, namely like sweet even more than what babies like? Babies like sweet, this is innate. But do we enhance that sweetness liking with the exposure during pregnancy? I want to briefly tell you what we're doing right now. This goes a little bit beyond endocrinology, but I think is really important. Namely, we know from rats that if you give them Splenda, their intestinal P-glycoprotein changes and is upregulated. I'll explain what I mean with that. So in the gut, so here is the gut. If you give, for example, rifampin. Somebody has tuberculosis. You give rifampin. Eventually, the person doesn't respond to rifampin anymore. It's not that the bacterium has become resistant. It's that the person has upregulated this PGP, this P-glycoprotein, so much that he or she doesn't absorb rifampin anymore. That's what that is. So this is the drug resistance protein, which regulates how much of a medication you absorb. And then, of course, we have the cytochrome P450 enzymes in the gut and in the liver that metabolize drugs. So both of these were shown to be upregulated by sucralose, by Splenda. And so we're saying if this happens in rats, what does that mean if that also happened in humans? And there is an example that I thought was really interesting, namely, in people who get organ transplantation, in our case, there was liver and kidney transplantation, who have to take cyclosporin. They were found to have all of a sudden low cyclosporin levels. And of course, the physician always blames the patient for non-compliance, right? You're not taking your medicine. The patient swears, I'm taking it. But ultimately it was discovered that these patients, after transplantation started taking over-the-counter medication, mild antidepressant, and that's St. John's wort. And what does St. John's wort do? It upregulates PGP. So they didn't absorb their cyclosporin as they should. And in fact, several patients lost their transplants because this was only discovered afterwards. So there is a case for something that's an over-the-counter medication that actually upregulates PGP and that can have serious consequences. So we said, why not sucralose? So what we're doing now is, I just explained that, what we're doing now is we give people a medication, look at the pharmacokinetics, that's that curve, before sucralose exposure, then we're giving them sucralose for 4 weeks, and we look and we expect this curve. Now that study is in the middle of being conducted. We only have 11 participants so far, so I don't know the answer yet. And anyway, they are double-blind, placebo-controlled, assigned to the various arms. So answer will be coming. One project I want to mention for the future, and if somebody here wants to do it, that'd be perfectly fine. There's so much to do, we can share the work. And this is, again, going back to what does that do to, what does artificial sweetener exposure do to babies? Does it do anything? Because just measuring the stuff in the various body fluids doesn't mean that there's an effect. So what we would like to do is we would like to work with women at Walter Reed. Walter Reed does the nice thing again about NIH. We are located just across the street from what was before the Navy Hospital, but now is combined Navy and Walter Reed. So there are a lot of scheduled C-sections, and what we would like to do is study in these women who have to undergo these C-sections later the microbiome in their babies, in their breastfed babies. So how do we do this? Of course, we get consent, and we get the history of these women about their dietary consumption, but I already showed you by our own data that that's not very reliable. And then we ask the women whether between 2 and 4 hours before the scheduled C-section, they would be willing to drink a diet soda. And that has been okayed by the anesthesiologist. So if they drink it, we know they have the artificial sweeteners in the system. If they don't, they say, no, no, thank you. We still examine them because they are our negative controls. And when the C-section is being done, you need, of course, the spinal anesthesia, so we can get spinal fluid, so we know how fast artificial sweeteners go into spinal fluid. And we can get a little amniotic fluid right when they open the sac and take out the baby. So we get all the fluids in a timed way. And at birth, we can sample cord blood, again, which we already know is 70% positive, placenta, meconium, urine. And then at a 2 months visit, we want to look at the microbiome of the babies. So microbiome of breastfed babies is a better target, an easier target than if I sampled us here and then I sample again in 2 weeks after exposure or something, because our microbiomes are so diverse. The microbiome of a baby is established, fully established after 1 year, at about 1 year of age. And when they're breastfed, they have a relatively narrow microbiome. So we hope to see a potential difference between exposed babies or higher exposed babies versus lower exposure. And with that, I just want to mention something for perspective, public health basically. And that is, where do you think we're going with all this artificial sweetener research? Because people might say, hey, Kristina, have you maybe seen the numbers, the sales numbers of Coca-Cola and Pepsi in the United States? Do you see they're going like this with regard to, they had a little blip with the smaller cans. But basically, fewer products are sold, fewer soda, diet soda, regular soda, is being sold in the United States and in Europe. We know this is not good. Okay, so So where is the novelty and where is the importance of all of this? If we all came to our senses and we are using less sugar, and then we learn that artificial sweetener really isn't the solution either. So where do you think, where's the importance? And I think that people in industry are so smart to say, look guys, there are other targets. So where are the biggest targets with the fastest growing population with obesity and diabetes? Because that's where you can sell artificial sweeteners. Right here, China and India. And this is where the markets are exploding now. And in fact, unfortunately, I read an article in the New York Times that Pepsi representatives are influential in Chinese health policy, in that they have supported research in physical activity and all these things away from research on nutrition. So I think this is where the next focus is, and to support that, it's not China or India, but I cut out this article from the Washington Post. This is July 12th, just a month ago. And it says, Latin America's war on obesity, lessons for the US. Sounds like we should learn something from there, taxing sugar-sweetened beverages and so on. I'm not so sure that we're really learning the right lesson. Namely, it says here in the caption underneath this figure where the photo, you don't really see the Coca-Cola cans very well, but that's what it is. Coca-Cola says that 45% of all its products sold in Mexico are now low sugar or sugar-free. So that's where we are. And I am saying, and my colleagues in the field are saying, it's not the solution. You think you're doing something good, but you're not. We need to get away from all of the soda stuff and all of these sweetened things. That's the problem, and nobody wants to do it because then you sell fewer products. Okay, so I think I have shown you that the prevalence of artificial sweeteners is underestimated, and that there are effects on glucoregulatory hormones, for example, the insulin secretion and a GLP-1. I really believe that the insulin secretion is what's mildly driving, it's like a piece in the puzzle, right? Mildly driving obesity. Promotion of adipogenesis, that's really in its early stages. That's a hypothesis. And exposure in early life, I think we're just in the beginning. We need to learn what that means for our babies. And with that, I want to thank you for your attention and thank my many colleagues. I'm proud to have this picture up there with all these fabulous women. Nothing against men, but we were so proud. In the middle is actually this lady here, all in black. That is Julie Manella, and she's the one who does these fabulous research on taste preferences, for example, in babies. I didn't know you can do this. You can test a 4-week-old baby, what he or she likes. And she does facial expression studies and all that. So that's where we got our onion and garlic stuff from. So thank you very much. Of course, I'm happy to answer questions.
Thanks. That was quite interesting. I'm curious from a practical standpoint, if I were working in obesity clinic, advising a patient on a weight loss strategy and saying they can continue drinking sugar-containing soda, diet soda, or water, what is the trajectory of weight in each of those three categories?
Yeah, so that's an excellent study because it points to the problems that we have in clinical research. So, for example, a study was done, and that's always being cited, that says, hey, look, when people go on a weight loss diet and they're allowed to drink diet soda, they do better than people who have to drink water. That's what the study shows. If you look, then you see that this was actually done in adults, in adult women. all of the women were soda drinkers before they got into the study. So when you take away from a soda drinking woman who now needs to lose weight, food and the soda, that's tough. If you give her at least the diet soda, that's better. So adherence is probably better when you have somebody who's used to soda and now needs to lose weight and you take everything away. That's a punishment. So the thing though is, and this was in a New England Journal article where you may have seen that, this was now published a few years ago, where school children were either randomized to drinking a regular soda during school hours or a diet soda. And then they were followed for 1.5 years. Excellent, right? I mean, this was done in the Netherlands. And lo and behold, the kids who drink on every day their regular soda, they gain more weight. The problem was, if you look at the Z-score for BMI, the kids with the diet soda were also above, and there was no water control. So can I tell you can I give you a straight answer, because I know from data that exists what happens? No. Because people feel that diet soda is an alternative, and therefore there are multiple studies with diet soda versus regular soda. And I think there's an additional problem, namely, people in general are not on a diet, on a weight loss diet. So when you are on a weight loss diet and you drink artificial sweeteners, you can lose weight, absolutely. But more importantly is what happens to you when you use artificial sweeteners, when you are on your usual. That's where I make the point. You can lose weight on artificial sweeteners. And maybe, as I said, it's less punishing for somebody. But ultimately, for regular life, it will promote obesity. It will promote weight gain.
The next question, so I'll use the mic. So one of the things that we know about artificial sweeteners is that they are more potent as a sweet taste. And so you talked about the location of different receptors, and so is that relevant to their impact on insulin secretion or GLP-1 secretion, that they do it because they're more potent at a smaller amount, or is that not an issue?
So that's also a good question, because when in the very beginning, when I showed you these various sweeteners, so sucralose is typically 600 times sweeter than sugar. But the point is, it's being used at concentrations that are equal with regard to sweetness. So it's 600 times less of the sucralose in whatever the drink or whatever it is. And so potency may be one thing, but sucralose is also a chemical which may not only act via receptors. So there may be other effects. So there are studies on sweet taste receptor knockout animals, and they still have effects of sucralose. So this one, the potency, I don't think plays such a big role. I'm sorry, but the non-receptor effects may play a role. The other thing is also, and many of you may notice that, when you drink artificial sweeteners, don't you have a little bit of that bitter taste? So sugar does not activate bitter taste receptors, but artificial sweeteners do. And the more artificial sweetener, the more bitter taste. So that's why in many products, there are low concentrations of various sweeteners, because at the low concentrations, they are only supposed to activate sweet taste receptor, not the bitter taste receptor. Some are inherently activate both at the same time. And so many people with stevia, for example, they are sensitive to it, they feel it immediately because it activates both receptors.
One other question is impact of artificial sweeteners in care of children with type 1 diabetes. Any insights or changes in
Yeah, we did this acute study also in kids with type 1 diabetes, and in the kids with type 1 diabetes, their GLP-1 response was much higher than in healthy kids. What that means, I really don't know, because again, we did not find slowing of gastric emptying, we did not find differences in glucagon concentrations, so I don't know. And there, I feel one needs to be pragmatic, because clearly the rise of blood glucose, if a kid with type 1 diabetes drank a regular soda, would be clearly very bad. So if a kid drinks diet soda, there is none of that rise. But I think ultimately, on the whole body, the effects are still similar to somebody who doesn't have diabetes. So if you ask me, type 1 diabetes, sugar sweetened or artificial, there's no question. Yeah.
You do your gastric emptying studies with acetaminophen. I assume that's a liquid?
Sorry?
I assume you're using a liquid acetaminophen product for your gastric emptying study?
Yeah, well, no, actually what we did is we made the pills smaller. So we grinded the pills and then gave it. Yeah.
So there's a difference between the emptying of solids and semi-solids and the emptying of liquids. And generally, gastric emptying studies are done with solids or semi-solids rather than with liquids. Have you done tests with solids or semi-solids to see whether that part of gastric motility is altered in your GLP-1?
I cannot answer the question, because all we did is we compared one oral glucose tolerance test to the next oral glucose tolerance test. So that means these volunteers only received liquid. They received the diet soda solution with the either sweetener or just water, and then they received 10 minutes later the oral glucose tolerance test, and in that glucola there was the acetaminophen. So it is one test to the next test, and we didn't see a difference, but I cannot answer the question, because that is correct, that whether solid food or liquid, there is a difference. But I think in this experiment it didn't matter, because we compared apples with apples. Each time it is this type of liquid. But there are better ways. There are better ways to study. So this was not the primary outcome. Otherwise, I would not have used it. It's a poor man's way of assessing whether there are clear-cut differences in gastric emptying. I agree with you.
So kind of stemming back on the first question, if you had a patient who was obese and also was at risk for type 2 diabetes or had type 2 diabetes, could recommending artificial sweetener beverages in place of soda potentially be harmful because of the increased insulin resistance, or do you still think the potential weight loss benefits would outweigh that potential increased risk?
So again, I'd like to answer the questions based on clear-cut knowledge and a study, and that study doesn't exist. But what I can tell you is that the patients, no, these were participants in one of the studies where these were obese women, obese insulin-resistant women, and when they were exposed to sucralose, they had significantly increased insulin concentrations. So yes, I think we need to get away from seeing diet soda as a solution and a good alternative to sugar-sweetened beverages. That's correct. I cannot tell you that this is harmful, because I haven't done this in type 2 diabetes. Can they still increase their insulin secretion from these somewhat damaged beta cells? I don't know that, but I think it's the wrong choice.
I'd like to thank Dr. Rother for her presentation, and if anybody has other questions afterwards, we'll be outside, so thank you very much.
Yeah, take that.
You have been disconnected from the meeting.